Welcome back to the deep dive. Today we are exploring one of the most hardworking and frankly underappreciated organs in your body, the liver.
It's an absolute chemical powerhouse.
It really is. And here's a stat that it puts its workload into perspective for me. Every single second, 25% of the blood your heart pumps goes directly through your liver.
That volume is staggering. I mean, we are talking about 1 to 1.5 liters of blood every minute.
And that blood is coming straight from the GI tract through the portal vein.
Right. It's carrying everything, all the nutrients you just ate, but also every toxin, every medication, every metabolite.
And the liver's job is, it's just so multifaceted. It has to synthesize key molecules we need to survive, like albumin, cholesterol, clotting factors.
While at the same time, it's clearing all those toxins. It all happens in this incredibly delicate structure, these little units called hepatic lobules.
And our mission today is really to trace what happens when that crucial architecture fails, specifically with cirrhosis. We want to focus on how that damage translates into these really shocking limitations on a person's ability to move, to think, and just live their daily life.
We're looking at the functional fallout, not just the cellular science.
So let's set the stage. How does this crisis even begin?
Well, when the liver is repeatedly damaged, whether it's from a virus, alcohol, or even fat accumulation, the cells die.
And scar tissue forms, fibrosis.
Exactly. And that fibrosis, that scar tissue, it doesn't just replace the cells. It completely destroys the internal plumbing of the organ.
And that destroyed plumbing, that leads to the two core problems that really drive everything else we're about to discuss.
Precisely. Problem one is pretty straightforward.
Mm.
The liver cells that are left just can't keep up. So you get impaired synthetic and metabolic function. But the second problem, the plumbing issue, is arguably what causes the most destructive physical symptoms. That rigid scar tissue, it basically creates a dam. It blocks that massive volume of blood trying to flow through.
A huge backup.
A huge backup. It builds up immense pressure in that portal vein system. And that condition, we call it portal hypertension.
And that pressure is the engine behind all this.
It's the engine driving so many of the most debilitating symptoms.
What's so insidious here is how silently this all progresses. I mean, the source material really emphasizes that liver disease can be completely asymptomatic for years.
It doesn't limit your activity at all in the early stages.
Right. For something like alcoholic cirrhosis, it can take a decade, maybe more, of heavy use to even start showing symptoms.
And by heavy use, we're talking more than 2 drinks a day for men or more than 1 for women, consistently. By the time someone feels limited, they're already in what we call advanced or decompensated cirrhosis.
End-stage liver disease, ESLD.
That's it.
So what are the main things pushing patients to that critical stage here in the U.S.?
Well, historically, hepatitis C was the leading reason for a liver transplant. Now, new treatments are changing that, which is great news.
But alcohol is still a major factor.
Alcohol remains the leading cause of cirrhosis deaths. And coming up fast behind it, driven by the obesity and diabetes epidemics, is NASH non-alcoholic steatohepatitis.
Fatty liver disease.
Essentially, yes. Fatty liver that progresses all the way to severe scarring.
Okay, so once a patient is that sick, doctors need a way to, standardize the damage and predict what's going to happen. I see 2 big classification systems mentioned.
Right. The first is the older one, but it's still very useful. It's called the Child-Pugh classification. It grades severity from A to C.
And what does it look at?
It looks at 5 key things. Bilirubin, to see how well the liver clears waste. Albumin, to measure its synthetic output.
Sure.
And then the big clinical signs, ascites, which is fluid, encephalopathy, which is confusion, and prothrombin time, which is your clotting ability.
And grade C is bad news.
Grade C is ESLD. We're talking a 45% 1-year survival rate. It's grim.
And what about the other one, the MELD score?
The Meldine-Lay score. It stands for Model for End-Stage Liver Disease. It's a much more complex exponential formula.
Exponential.
Yeah, and that's the key. A small jump in your score means a huge jump in your risk of death. It's mainly used to figure out who's sickest on the transplant list.
So a higher score gets you higher priority.
Exactly. The source material notes that patients at big transplant centers, they often have MELD scores over 30 by the time they're ready for surgery. They are living right on the knife's edge.
And that really sets the stage for the physical breakdown we need to get into.
It does.
Okay, let's unpack this. Forget the lab values for a second. What are the tangible mechanical things that are actively stopping a patient from moving?
The first and honestly the most debilitating is ascites.
The fluid.
The fluid. Because the liver is failing and that portal pressure is so high, the body just holds on to massive amounts of sodium and water. This fluid gets forced out of the blood vessels and just fills up the abdominal cavity.
We really have to emphasize the sheer volume here. This isn't just feeling a bit bloated.
Absolutely not. We're talking 10 to 20 liters of fluid. That's 20 to 45 pounds of extra weight.
Wow. Imagine strapping a toddler permanently to your stomach. That has to fundamentally change how you move.
It changes everything. First, that weight causes intense abdominal and back pain.
Yeah.
Second, it messes with your gait, your balance. Your fall risk goes through the roof.
And I imagine it's hard to breathe.
It's incredibly hard. The fluid pushes up on your diaphragm, so every breath is shallow. Just tying your shoes or getting out of a chair becomes this monumental effort.
And while the patient is fighting all this fluid, their body is also starving. Cachexia.
Cachexia, yeah. Severe muscle wasting. And it's a triple threat. First, patients have a terrible appetite because of the toxins and just the pressure from all that fluid.
They feel full.
They feel full all the time. Second, the liver can't store or metabolize fuel properly.
Yeah.
And third, when we drain that fluid off a procedure called paracentesis, they lose a ton of valuable protein along with it.
So you have this functional irony. The patient is getting weaker and weaker, but the scale might actually be going up.
That's the really deceiving part. The ascites and the edema in their legs can make their body weight increase even as their muscle mass is just melting away.
Yeah.
So you have extreme weakness combined with this heavy, fluid-filled body. It's a recipe for falls.
Okay, so moving from the physical to the cognitive, this is where we hit the other huge barrier, hepatic encephalopathy, HE.
Yeah, this is a crisis that affects 50 to 70% of patients with severe cirrhosis. Basically, the liver fails to clear critical neurotoxins, mainly ammonia.
Ammonia from protein breakdown in the gut.
Exactly. But it also fails to clear other things, like compounds that act a lot like benzodiazepines.
Like Valium or Xanax.
Right. They have this sedative, tranquilizing effect on the brain. When these toxins build up, the results are just devastating.
What are the first signs? How does it start?
Early on, it can be really subtle. The source material points out that an increase in traffic accidents can be an early indicator.
Because the reaction time is off.
Their judgment, their reaction time, is just a little bit slow. They also start to get this sleep cycle reversal. They're drowsy all day, but restless and confused at night.
And as it gets worse,
it progresses to poor memory, poor concentration, lethargy, severe disorientation. They might not know what day it is, where they are, and it can lead straight to stupor and coma.
their physical signs too?
Oh, yes. Slurred speech, poor balance ataxia, and the classic sign we look for is asterixis. It's this distinctive flapping tremor of the hands.
A flapping tremor, that must make basic self-care just impossible.
Completely. Imagine trying to eat or write or shave when your hands are uncontrollably flapping. From a therapy standpoint, HE is a brick wall. The patient can't learn anything new, they're too drowsy to cooperate, and sometimes they can get anxious or even belligerent. Until that HE clears, rehab is just off the table.
And it seems like these HE episodes are often triggered by something else going on.
That's the challenge.
Yeah.
It is reversible, but you have to find the trigger. And common triggers are things like an infection, a GI bleed, dehydration.
Maybe from using too many diuretics.
Exactly. Or even giving them certain psychoactive drugs like narcotics. It's a constant juggling act.
Which brings us to a really fascinating point. The very medications you use to manage these complications, they introduce a whole new set of risks.
They do. It's an incredibly tightrope to walk. The treatments themselves create new dangers, especially when it comes to falls.
Okay, let's start with the diuretics for ascites.
Right, so we use drugs like furosemide and spironolactone to force the body to get rid of all that extra fluid, but the intended effect is frequent urination.
Which means lots of trips to the bathroom.
Urgent trips. Furosemide, especially 5E, can make you have to go and go now within 30 minutes.
So you combine that urgency with someone who's already weak, breathless, carrying 40 pounds of fluid, and maybe confused. A nighttime rush to the bathroom sounds like a catastrophe waiting to happen.
It is. And if you're too aggressive with the diuretics, you cause dehydration, low blood pressure, dizziness. It all just compounds the fall risk.
And then there's the main treatment for the confusion for HE lactulose.
Lactulose. It's a non-absorbable sugar that basically works as a laxative. The whole point is to bind the ammonia and carry it out in the stool.
And the goal is what, 2 to 4 bowel movements a day?
2 to 4 soft bowel movements a day. That's the ideal. But the reality is that patients often have way more than that. The side effect is severe diarrhea.
So again, urgent toileting.
Again, urgent, frequent toileting in a patient whose balance and judgment are already impaired by the HE. It's just another huge fall risk.
Or finally, you have to manage the risk of this life-threatening bleeding with beta blockers.
This is one of the deadliest complications. Portal hypertension can force blood into these fragile veins in the esophagus. We call them varices. If they rupture, it's a massive, uncontrolled bleed. Beta blockers lower that pressure.
But they lower blood pressure everywhere.
Everywhere. They cause generalized hypotension, a slow heart rate, and most disruptively, orthostasis. That's the dizzy spell you get when you stand up too fast. Layer that on top of someone who's already weak and unstable.
So if you step back, you see this perfect storm, this danger triangle.
That's a great way to put it.
You have a patient who is incredibly likely to fall from the ascites, the HE, the weakness, the meds, and that same patient has an incredibly high risk of bleeding because their liver can't make clotting factors and their platelets are low.
It is the worst possible combination. A simple fall, a bump on the head from tripping on the way to the bathroom could easily be fatal.
Given all of that, the only real cure is a liver transplant. And this brings us back to the importance of physical condition before the surgery.
It's absolutely critical. Patients who are deconditioned or severely malnourished, they tolerate the surgery very poorly. They have much longer, much slower recoveries. The goal before transplant is just to maintain nutrition and strength as much as possible.
Because the surgery itself is a massive physical trauma.
It's an immense operation. 8, 10, 12 hours. Complete removal and replacement of the liver through a huge incision. The recovery is daunting.
What are the immediate hurdles post-op that get in the way of moving?
Right away, you're worried about bleeding. That requires transfusions, which leaves you incredibly weak. You worry about hypotension, low blood pressure, which causes dizziness. Infections are a huge concern, often drug-resistant ones, which means isolation and limited movement. And then there's just the pain from the incision.
And once they get past that acute phase, they start on the immunosuppressants to prevent rejection.
And those bring their own set of movement-related side effects. The most common one, tacrolimus, very frequently causes a tremor.
The flapping tremor again?
No, this is different. It's a postural tremor and an intention tremor. It's often so severe, it interferes with fine motor skills. Writing, using a fork, buttoning a shirt, it becomes impossible.
And what if they need long-term steroids?
Steroids are powerful, but they come with huge functional risks. They cause weight gain, mood swings. But physically, they cause muscle weakness, especially in the hips and shoulders, making it hard to climb stairs. And long-term, they increase the risk of osteoporosis and fractures.
So even a successful transplant is just trading one set of problems for another.
In a way, yes. The message from the surgical teams is always the same. The key to a full recovery is adequate nutrition and a successful, sustained return to physical activity. The patient has to fight to get back what the cirrhosis stole from them.
This has been a really insightful look at the total system failure of advanced cirrhosis. To sum it up, the barriers are just so clear. You have ascites, which destroys mobility and breathing.
You have hepatic encephalopathy, robbing patients of their cognition, their ability to cooperate. And cachexia, causing just devastating weakness.
And on top of all that, the life-saving medications, the diuretics, the lactulose, the beta blockers, they actively create new dangers, multiplying the risk of a catastrophic bleed from a simple fall.
I think the biggest takeaway, though, is the contrast you can see. It's often the progression to chronic scarring that causes this debilitating functional decline, not just the liver's metabolic failure on its own.
That's a really key point.
It is. If you look at other severe liver diseases that aren't cirrhotic, the picture is different. Take fulminant liver failure. That's an acute rapid shutdown over just a few weeks.
The patient gets sick fast.
Very fast. They might look relatively okay until the encephalopathy hits, and then they can go into a coma very quickly. They're critically ill, but they haven't had months or years for their body to physically break down.
As opposed to someone with, say, liver cancer.
Exactly. A patient with hepatocellular carcinoma might tolerate a transplant much better functionally because they may not have those 3 crippling symptoms of advanced cirrhosis. They might not have the severe ascites, the cachexia, or the recurrent HE that just grinds a person down before they even get to the operating room.
So it's the chronic structural damage, the cirrhosis itself, that is truly the physical gauntlet. A great reminder that pathology is always profoundly connected to a patient's function. Thank you for taking this deep dive with us today.